Hello, good afternoon, everyone. To those of you on the East Coast and those of you on the West Coast joining us, thank you. Good morning to all of you. My name is Dr. Astral Webb, and I am the director here at the National Center for Health and Aging. I want to thank and welcome all of you to today's topic, which is making community connections, chronic disease self-management education in your federally qualified health centers. And the discussion today is centered around making this part of your patient-centered medical home transformation. So we are really delighted. We have a wonderful lineup of speakers today. And at the end of the presentation, we will take any questions that you have and try our best to make sure that our expert panelists have the opportunity to answer the questions for you. So today we're delighted to have Ms. Christy Lynnzy, who is the Senior Program Manager with the Center for Healthy Aging at the National Council on Aging, as our moderator for today's webinar discussion. She provides training and technical assistance, guidance, and program management to state government agencies and community-based providers implementing evidence-based health promotion programs like including Stanford University's Chronic Disease Self-Management Program. So Christy, thank you so much for agreeing to moderate today's session, and I will now turn it over to you.
Great. Thank you, Dr. Webb. And I'd like to introduce our two speakers and then toss it over to them so we can get started with our webinar. We have Chris Katzenmeyer. She's a gerontologist and the Executive Director of the Consortium for Older Adult Wellness, dedicated to training professionals in evidence-based programs that enhance wellness of older adults. COAW is also successfully focusing on the bridge that reimburses community programs when older adults are referred by clinics via the Affordable Care Act. Chris was the coordinator of the statewide Senior Wellness Initiative and is an adjunct professor at Metro State College. She received the 2010 Denver Business Journal's Champion in Healthcare Award for providing innovative and effective new strategies in healthcare. And joining Chris is Lynnzy McIntosh. Lynnzy is Vice President at the Consortium for Older Adult Wellness. She trained to be a chronic disease self-management program leader in 2008 and joined COAW's staff later that year. She now supervises implementation of evidence-based programs throughout Colorado, including integration of falls prevention and self-management classes into health systems, as well as individual practices seeking national recognition as patient-centered medical homes. She also is the first chair of the new Colorado statewide CDSMP, or Chronic Disease Self-Management Program, collaborative, and starting in January, will be working on behalf of the collaborative with the State Unit on Aging and Healthcare Policy and Finance on a voucher program for Medicaid reimbursement of the Chronic Disease Self-Management Program. So now I'd like to turn it over to Chris and Lynnzy.
Hello, everyone, friends and colleagues. Thank you for asking us to do this webinar. We are very happy to share this information with everyone. As it was stated, this is making community connections, chronic disease self-management education in federally qualified healthcare centers. We hope this presentation will spark and assure you that CDSMP, or the Chronic Disease Self-Management Program, can be implemented successfully in a federally qualified health center. Some of the learning objectives that we would like to share with you is to really help to assist you in initiating this program, the Chronic Disease Self-Management Program within a federally qualified healthcare center, and then have an open discussion at the end of this presentation to really talk about the connection between chronic disease self-management and a patient-centered medical home. We really hope this fosters a collaborative interaction between patients, providers, and community-based organizations. And I want to emphasize again that we are very happy to be able to share this information based upon successful models that have happened here in Colorado. Just very briefly, the Consortium for Older Adult Wellness is a nonprofit organization. It was founded in 2001. And we are really a consortium of like-minded organizations that are working in healthcare and with the Affordable Care Act, really looking at patient-centered care. And we're doing this across Colorado and with some friends in other states as well. Our major focus is just on increasing the health options for older adults. And if you want to know more about us, we're at coaw.org, coaw.org. I want to just move on so we can get to the meat and potatoes of this today. So what I would like to do now is turn this over to my colleague, Lynnzy McIntosh, who really has done the pioneering for all of us in this work. So, Lynnzy.
Well, thanks. Pioneering.
Pioneering.
I like that. Well, welcome, everybody. We are very happy to be here. I want to start out with a couple of shout-outs. First to our pal, Dr. Webb, who just completed her training to be a leader in chronic disease self-management out in Colorado with us. Also, hello to Judy Simon and her friends and co-workers from Maryland, as well as our friends here in Colorado that are AAAs and also members of our statewide collaborative. And as well, I want to especially acknowledge the Colorado Community Health Network, which is the organization including Renee Carl, who hopefully is on the call with us, who is our partner in the work we're doing with the federally qualified health centers. And in particular, of course, our thanks to National Council on Aging, who have shared so much with us and have supported us in so many ways, not just us, meaning COA, but all of us in making all of this work happen. So we're very happy to be here. So we're going to start with what is self-management. And I know that all of you on the call are at very different places in what you're doing and how you're doing it. So forgive me if I repeat some things that you already know. Just sort of nod your head and we'll get through them quickly. And if it's information that you don't know, hopefully it will be enough to get you started. And then please be in touch with us and let us know if there's anything we can support you in furthering your knowledge, or if you have answers for our questions. We really want to hear from you because answers are always more exciting than anything. So what is self-management? When we start working with clinics and with health systems in general, one of the big questions is, what is the difference between self-management, medical management, self-management support? And so this is the official definition. How I like to talk about it, though, is a little different because I think this definition makes it sound very formal. But if you figure that if I'm a very sick patient, I spend about 3% of my time with my healthcare system and providers. That means 97% of my time I am spending making my own decisions and choices. So the medical management piece, you all can handle in that 3% of the time, and then you give me instructions, advice, directions, procedures, tests, medications, et cetera, but that 97% of the time, I need to make choices and changes and decisions on my own. And it's that 97% of the time that's addressed with self-management. Self-management support, if you will, is the part of, that the practice can be involved with and the clinic can be involved with that helps me make choices and changes that are in my own best interest, or at least will minimize choices that I'm making that might not be in my best interest. But the self-management support piece is all the ways the clinic, the staff, the health system can support me as the patient in my own self-management. So how does that self-management piece work within the whole healthcare transformation, patient-centered medical home movement, patient activation, and most importantly, within your organization? And I realize on the call today we have people that are here because they are community-based organizations. They are AAAs. They are also from the FQ world and from the clinical world. So we're going to try and talk about it from both perspectives as much as we can within the time we have. Self-management is really, we see, is a pivotal piece of everything that's happening in healthcare transformation, because the patient is really the center of the activity. The problem is that we haven't always shared that with the patient. So we need to start the whole conversation when we're talking about self-management, self-management support, care coordination with, have we talked with the patient about what we can do and what they're going to be responsible for doing. Self-management in terms of patient-centered medical home recognition, PCMH is all about changing the way healthcare works and changing the perspective from being one of a fee-for-service base and from a view of a gatekeeper perspective to something where what I'm doing as a patient is really seen as the center of what's happening and that everyone is surrounding me and supporting me. So the 2011 NCQA, National Center for Quality Assurance Guidelines, really reinforce the critical role of the patient's decisions, choices, and what they're doing, and really recognizes that. That includes the need to document the capabilities the patient has for self-management, also to document self-management goals, and to give tools and to provide resources and to document that as well. Also to provide counseling on healthy behaviors, and for those of you, especially in FQ world, know that behavioral medicine, behavioral changes are really a key factor to the overall health of the patient, and that also may involve a lot arranging things like mental health intervention, substance abuse treatment, and then to provide that link to community resources, not just to have a book at the front desk within an FQ that says here's all the different agencies we know that do everything, but what specific community resources work with the patients that you are seeing in your practice. This is an overview of what the PCMH standards are. And again, it's those of you who have been doing a lot of this work, and this is the work that we've been doing with Colorado Community Health Network. These are all of the 6 standards for NCQA. And what you see is if you look at all of them, this first one is access and continuity of care, which involves when do you see a patient? How do you make it easier for patients to come in? How do you provide culturally and linguistically appropriate services? Talk about being something that supports the patient. Knowing you can get in to see your physician and why they care what your first language is or your choice of how to be communicated with. Talk about something that will really help establish a relationship with the patient and make them feel involved. That's the beginning from the very first standard there. There's also things like patient panelment. And if you look down at standard number 3, that is to plan and manage care. And that involves the whole care management care plan for a patient, which can include a treatment plan, but also includes the self-management goals that the patient has. So if you look at a big umbrella of this is the whole care management of what we're going to do with our patient. There's a piece of it that's all the clinical things. My patient is diabetic. My goals for this patient are to lower the A1C levels and have them become compliant with their medication. To do that, we're going to have them do a diabetes medical intervention class. To do that, we're also going to put them on medication. And then we have their self-management goals, which might include referring them to a community-based class. So you go into then this standard, PCMH 4, which is to provide self-care support and community resources. That self-care support is really what is my patient going to do with the 97% of their time, and how can I help them make those connections. That includes being able to document goals on what I want to accomplish as a patient and my ability to do that. Also the referrals that are being made to things like a quit line, to a chronic disease self-management class. So we're going to talk more about that. But I get excited because it is such an integral part of what NCQA is about. And we really have found in Colorado that putting self-management support at the heart of that makes it easier for the patient to understand the transformation, but also really makes it easier for an FQ staff to understand the importance of the transformation. So clearly it's important. We like it. We want more of it. So what I want to say about that is that when FQs are going through, or any practice, when you're going through your application for patient-centered medical home, you document everything. I mean, if you look at all of these different components, you are measuring, you are tracking, you are coordinating, you are documenting, you are making graphs. And I can see all of you on the call nodding your head that have been doing this work. But the truth is, engaging the patient, engaging me in the office is the only way to really impact those clinical outcomes. You can measure processes all you want to. You can weigh me 10 times a day. You can take my A1C every moment of day and night. But the only thing that will change those numbers is if I move differently, if I eat differently, if I actually take my medication as directed, if I follow your advice, if I make better choices. All of that is on me to do. And so that's what makes those A1Cs go down. That's what makes my ability to deal with my condition go up. So clearly, that's a brilliant idea. Having me be an involved, activated patient, teaching me all about self-management and my role in my healthcare, that's all good. So when we talk to practices, we say, why can't we do this? Why can't we do this? And the answer would be what you see on your screen there, which is time. Time. You just don't have time to sit with a patient for hours and hours and talk about the difference between clinical management, self-management, self-management support, your role, their role, et cetera, et cetera. And as a patient, we have gotten in the habit, and I include myself in this, in thinking that I can go to my provider and they will fix it. And to come to the understanding that it is not yours to fix, that we can work on it together, but there are no magic pills, is really hard for us to understand within the confines of a regular traditional time in an office. So how do we do this? What do we do to help make this work? Well, what we suggest is that you don't try and do it all within what's happening within the clinic, but that you really lean on one of the skills that we have available to us, which is the art of referring to community-based resources. Now, that includes not only something like a QuitLine or a Silver Sneakers program, but to those community-based, evidence-based programs that are available all around you, and sometimes in some communities are a really well-kept secret. So we want to talk about what's available and how to connect with them, both from the clinical side and from the community-based organization side. So what makes self-management work for you and within a clinical setting is that this is not something that is going to interfere with medical management at all. In fact, those of you who are familiar with evidence-based programs know that they have very clear definitions of what they do, what they don't do. And why, you may be asking, what is an evidence-based program? Why an evidence-based program as opposed to something we can write within the practice? The reason for that is an evidence-based program, much like evidence-based guidelines, are the gold standard. They have been researched, they have been demonstrated, documented, can be replicated. And that's what is necessary not only for best practices within your practice, but also is the key toward eventually having these either reimbursable, paid for, grant-driven, however the funding sources look in your area. But it's based on evidence-based programs. It's based on, are they on the NCOA list? Are the classes on the Center for Disease Control list? So all of those things are very important, and that's why evidence-based programs are what really drive it. It's a model that can be demonstrated and conducted again and again. Fidelity is a big component, so that the classes we're doing here in Colorado are the same classes you're going to be doing in Maryland or Florida or Texas or California, and that's very important across the board. The reason that we talk about the self-management program, especially the chronic disease self-management program, as really the foundation piece, is that it really uses multiple strategies, multiple interventions. It's designed to help activate a patient. It is not necessarily designed for patients who are already triathletes, because if you're a triathlete and you come to talk with your clinician, you have a very different conversation than someone who is a couch potato or has 4 comorbidities and is socially isolated. Those are very different conversations. And what we're talking about are those patients that are deactivated, those patients that are the couch potatoes that maybe don't yet have a sense that they have choices and options in their own lives and in their own care. The chronic disease self-management program really helps promote connecting that patient with other folks that are in a similar situation, so that no matter what their diagnosis, they realize there are other people going through similar issues. It also is a way for the practice to move all of this off of their plate and share the load a little bit with the community-based organizations who can then help support your patient in making the changes that you are hoping they will want to make. So move along here to what exactly is the chronic disease self-management program. This one, again, we use it as a foundation class because I like to call it a gateway class, sort of like a gateway drug, but this is a gateway class because this is one of those classes that literally you see light bulbs go on over people's heads. And I know that sounds like I'm overstating it, but anyone who's ever been in a chronic disease self-management program class has witnessed it. And it's that moment when we realize that the chronic condition we've been living with is ours, and that because it is ours, there are changes we can make that will help us feel better. We maybe can't get rid of it, but we can affect it. So the Chronic Disease Self-Management Program out of Stanford University, written by Dr. Kate Lorig, over 20 years of proven impact. It's just the gold standard for this kind of work. It is offered in small venues. We've had it in coffee shops, in church basements, in recreation centers, senior centers, all the way up to classes within federally qualified health clinics, which we'll talk about later. It's offered around the world. It's available in 21 languages. There are programs within the chronic disease self-management education portfolio that are specific to diabetes. We've just been involved in some translational research, evidence-basing a new cancer survivor curriculum that's also out of Stanford that's chronic disease self-management. There's also a curriculum for pain management. There's one for HIV/AIDS. So there's a number of different things that all operate on that same premise, which is that people with ongoing health conditions have very similar problems, concerns, and that you need to deal not only with their condition, with the story of the diagnosis, but the impact that it makes on your life, the impact it makes on your emotions, and how to manage those things. The other part of this that I think is really important is that the programs are lay leader-led as opposed to healthcare professional-led. In fact, the research would show that they are just as effective, if not more effective, when they are led by lay leaders, which means that they are more cost-effective as well. So the class itself is 6 weeks long, 2.5 hours a session, and tell me how you're going to find that much time with a deactivated patient within your regular practice schedule. It's just not going to happen. So referring to a community-based organization is the way to make it work. Within the class series, they're going to be learning and be exposed to exercise and nutrition information, medication management, stress management, falls prevention, also how to talk with their doctor, communication skills, not only with their doctor but with their family, how to deal with difficult emotions and depression, how to breathe, how to do distractions so they can help manage not only difficult emotions but pain management, and the art of action planning And action planning is what relates directly back to goal setting, and documenting of goal setting is a part of what you need for patient-centered medical home recognition. So it all works together. You know, I would tell you that we frequently get asked how we're going to get people into a class where they have to sit for 2.5 hours. And the truth of the matter is, it always comes up, it's always a question, and it isn't an issue for the people in the class. They make it work because they're getting something out of the class. There are many different types of interaction that take place in the class. There's lecturettes, there's brainstorming, there's a lot of interaction. The 2.5 hours goes very quickly. I mean, we have people who, we just finished a class where a lady brought her own chair. Not just her own pillow for the chair. She literally brought her own chair, her own food, her own water. But that would be a different story. But anyway, the idea is that this will not stop people. So the benefits to the practice: external resource, don't have to recreate the wheel. It's going to reinforce a feedback loop to the practice on what your patients are really concerned about. You can document it in terms of patient-centered medical home terms. Definitely shifts the interaction with the patient. There's quality measures. It gives you data that you can document not only on the referral, but on the patient's goals and on updates on that. And it just really helps all the way around. In terms of the community-based organization, what it can do is help a community-based organization make those classes more accessible to the folks you want to serve. It gives you a way to reach people who are socially isolated, who are isolated by their medical conditions. So in terms of results, the program that we're doing right now is Colorado Community Health Network. We're working with 10 new federally qualified health center sites in collaboration with them. Their goal is to get their patient-centered medical home NCQA applications in and receive at least a level 1, hopefully level 3 all across the board. So right now, 6 out of those 10 are active in one way or another. 4 more will become activated. That would be practice activation as opposed to patient activation, but by the winter of 2012. These range from very large multi-site FQs to very small frontier locations where there is one provider on site and they're an FQ. 8 of the 10 practices that we had discussions with within this cohort will eventually have classes in English and Spanish. 5 of the 10 of them are now offering classes on site. And when I say on site, I mean within the federally qualified health center, either in the conference room after hours, in the front office after hours, during hours, in a classroom, many different ways, but actually on site. 5 of the 10 of those have now trained at least one person in the CDS-MP curriculum so they can lead classes. Not all of them are planning on doing the classes themselves, but by taking the training and understanding the curriculum and how it works, they're able to explain it to patients, providers, and really train the rest of the staff. We have a lot of important work that's done with the front office staff and the back office staff in terms of involvement in the referral process and the follow-up process. Referral results. The referral results that we have gotten have been really good. 26% now of all of the work that we do across the state is a direct result of a direct physician referral or a provider referral. We have noticed that roughly 50%, 52% of people that are referred by their provider, we can reach and go into the next available class that's being offered to them. Additional numbers we follow up on, those 50, outside of that 52%, we follow up with them as much as we can. We have people that it takes us a while to get to them because what we see with our work is the same thing you see in the practice in terms of difficulty getting them on the phone sometimes, difficulty in communicating with them in terms of how important something is for their health, transportation issues. But of the people we have reached, we've had them say, I can't do it now. Sometimes we don't reach them. 52% of them say they will come and they do attend the next session. but we've never had a person who's referred by a physician saying, no, I'm not going to do it. So that's good feedback for us. And then what we do is give that information back to you. I want to spend a little time on the process and the details for how we make this work. This is really important for how the community-based organization works. Each of these boxes represents a lot of time and skills and talent, so it's hard to talk about this in any great detail. We're going to share with you a little bit later how we can get more of that information to you. If you want more information, please email us or ask questions at the end of this. We start out meeting with the practice and doing some messaging and training. We also make a point of discussing with the practice who's going to be involved in self-management support. What does that mean? Then the clinician introduces the opportunity for the class to the patient. The patient then signs a referral form, or a referral is done. We work with the clinics so that the referral is handled the same way they would handle a referral for, say, physical therapy, so that the patient takes it seriously and the provider takes it seriously. Then from our end, we at COA and in the community-based organizations, they would contact that referred patient and they would enroll them in class. Now, we spell all of this out in a care compact that we actually do with the practices. We really encourage all of the community-based organizations we work with to do that same thing so that you know the expectations and they're clearly spelled out. COA then communicates weekly back with the practice to let them know who we've been able to reach, who we haven't reached, and what we've learned. Sometimes what we learn is the patient doesn't understand why they've been referred, because they may have oxygen tanks, arthritis, 5 comorbidities, but if they don't understand that those are chronic conditions and there's something they can do about them, then we can feed that information back to the practice and you can have a conversation with the practice or with the patient. The patient then attends the chronic disease self-management class, and as part of the program, we ask them to write a letter back to the practice at the end of the 6 weeks talking about what they've learned, what they understand now about managing their condition, and most importantly, what their goal is for the next 3 to 6 months. This gives you something you can then follow up with the practice. And this is what the referral form looks like. It's very simple. It has a place for the patient to sign, so it's HIPAA compliant. We ask that these be faxed in, but we also have a centralized referral system, so we do have HIPAA compliant ways for those to be emailed to us as well. And we can work with EMRs if need be, and so that things can come directly from the EMR to us. This is that feedback form, and this has evolved over time. I want to draw your attention just to this bottom piece that talks about my action plan for the next 6 months. So in this case, my goal is to stay healthy for as long as I can. I want to be here to see my grandkids graduate. That's your motivating factor right there. The specific action they're going to do is to walk with a neighbor. They're documenting 3 times a week, Monday, Wednesday, Saturday, and their confidence level. Those things are all things that need to be documented within the patient chart for NCQA. So all of that information is there and is a start and gives you something really good to talk with the patient about. Now clearly that's a whole lot of stuff we went over in a really fast way. So what we've discovered is that we need more time to really sit down with folks and go through in detail. So Chris can tell you a little bit about this opportunity. That's a good word for it. What we're doing in January, which, by the way, is ski season in Colorado.
I'll make this very brief because I know we want to move into question and answers. But we've had a lot of questions about how this works in detail. How do the details work? Is this hard work? So what we're going to do is we're going to have a workshop in Denver in January, and here's the information here. We will give our phone information at the very end here and our email information. So if you would like to come to Colorado in January, we'll take good care of you and hopefully give you all of the nuts and bolts that you need to do this in your area.
I would just like to say that our presenters are going to be coming not only from the National Council on Aging, but we will also have folks here from Healthcare Policy and Finance, Colorado State Unit on Aging, also our friends at Colorado Community Health Network, who's our FQ group, Colorado Foundation for Medical Care, and Health Teamwork. And what we really want to do with this is to take all those questions you have about how you do this in your particular situation and with your particular FQ and with your particular community-based organization, and what does a care compact look like, and to give you samples and have a chance to work through it. So
one other point, I guess, we will have a lot of video from people in the FQs that are actually doing this work. So we're going to put a lot of videos together so they can come to this particular workshop and share with you how it's actually working within the FQ. We hope you can come. It's really not that snowy in January.
Not in Denver.
Not in Denver.
But there's going to be good snow on the ski slopes.
Yeah.
Okay. So I just want to close by saying thank you. We're going to take a bunch of questions. That's how you contact us. And the big thing I want to say is that we've been fortunate enough to do this work now with federally qualified health centers, as well as individual practices of all different sizes who are working on their patient-centered medical home work. And it is not something that it is not incredibly difficult to do, but there are many moving parts. And we have learned many lessons, and we are happy to share how not to do it.
As well as how to do it.
Yeah, but how not to do it saves you some time.
Yeah.
So that's it, and I'm going to turn it back over to Christy, I think, so we can hopefully answer questions, or you guys can give us answers.
Great. Thank you so much, Chris and Lynnzy. That was a great presentation. And for those of you who have a question and haven't typed it in yet, I do encourage you to use the chat box on your screen. And we have had a couple that have come in. And I just want to remind everyone that if they are interested in learning more about the Chronic Disease Self-Management Program, or even in learning more about the agencies or organizations that are offering the program in their state, who they can connect with, they can find that information on our website, which is NCOA, for National Council on Aging.org. And just search Chronic Disease Self-Management Program, and you'll find the information that you need. So our first question, you spoke about the role of community-based organizations in offering the program, but then you also touched on the federally qualified health centers that you're currently working with, that many of them are offering the program on site, so they're delivering an internal model. So if a federally qualified health center is interested in offering CDSMP on site within their organization, do you have any suggestions for the best type of staff? So would it be a nurse, a medical assistant, health educator, et cetera, to train as facilitators, especially given the intent of the program to be a lay leader facilitated model?
That's a really good question. I would say what we have seen is MAs are wonderful at this. Patient navigators are wonderful at this. We've had front office staff who have always wanted to be more involved in patient care in some tangential way, and so this gives them the opportunity to be a part of the process. I will also say that although the model is not designed to be a medical model, we've had nurses and retired nurses that are great at co-leading the program. One of the things that we talk about a lot within the curriculum is taking off your medical hat and really sticking to it being a lay leader presentation of the material. In fact, it's really important that within the classes, anytime a medical thing comes up, we refer people back to the clinic or back to their provider, and that's just sort of standard operating procedure. I would say whoever within, if you're working on patient-centered medical home recognition, there's usually a QI team, and there are people within that team that are really excited about the whole transformation. And those are the folks, no matter what their title, that are really good at this work. We've had paramedics, we've had EMTs, but I think also MAs are a great untapped resource.
And just to piggyback, just in support of the MA part of what Lynnzy's saying, is oftentimes, we've been learning is oftentimes, there's a MA turnover, medical assistant turnover, and we have seen MAs embrace this program, and really the whole work, their whole work turns around. They really feel very purposeful, and we love seeing that very, very much.
Thank you. And do you find that trained staff can only lead classes in their place of employment, or how has that worked with the federally qualified health centers that you've partnered with? Or are they able to offer workshops in the community, perhaps in locations that are more accessible for the patients who need access?
All of the above. What we try and do is to talk with whoever the agency is that's working with training the leader. So if it's an FQ, we would talk with them about the fact that, clearly this is somebody they're trained with the intention of them working within the FQ. We also will talk with them when they train as a leader about their availability to help with other classes within the community. And we're in a position, what we do is stipend those, so they are like a paid volunteer to do that. So we really work on an individual basis. Sometimes we find that within certain communities, the thought is that a class is better not held at a health facility, that they want the class at the community center, at the health department, at the local bank, at the coffee shop, rather than within the practice. Frequently, though, we also find that they want it within the practice because they know the patient knows how to get there. So you can really kind of make a case either way, and that's why it really varies community by community, and why community-based organizations working with the FQ can really help answer some of these questions. But when we train a leader, we try and present it so that they have knowledge that they may, at least from our perspective, have the opportunity to teach additional classes on top of their regular workload, if they want.
Thank you. And we've had a couple of questions that have come in specific to cost and or how the program is funded through the FQHC, either what funding sources or just in general what resources go into supporting the program.
That's a complex answer, and I'm glad it came up because it's everybody's question. The work that we're doing currently to help support federally qualified healthcare centers to get the chronic disease self-management program embedded is through a partnership with the Colorado Community Health Network, which is also through a grant from Kaiser Permanente. So the work of getting the NCQA status and the self-management component embedded is through that part. But once you do that, then there's the work of keeping the class going, and keeping the class going not only for the federally qualified healthcare center, but also having trained leaders available to teach the class. So that actually is a different funding stream at this point for us. The training dollars are generally paid for by the federally qualified healthcare center or a clinic that's becoming a patient-centered medical home. The other part of, so you have that cost sharing, and then the cost of technical support to keep that moving is actually through the Consortium for Older Adult Wellness, and we have different kinds of funding streams for that. But the other piece that's just happening in Colorado that we're very excited about is the Medicaid voucher, and also we're doing some voucher work from our grant from the Administration on Aging. So with that combination, we will be able to help the federally qualified healthcare center receive some reimbursement to be able to support this program ongoing.
The goal is to make it as sustainable and workable on an ongoing basis. I think what gets expensive for the clinics is to start, then stop, then start again. So if we can help them really embed the program, embed the referral program, and then see the positive outcomes with their patient, that really is what makes it workable. So that if they realize that we can help reduce their workload rather than add to their workload. That's really helpful. And I would say that the FQs where we've worked have seen that it's well worth their time in terms of investment. When we are working with the grant dollars, either through the AOA and our partnerships with the State Unit on Aging or with the Medicaid vouchers and our partnerships with healthcare policy and finance, our goal is to really help strengthen the relationship of the community-based organizations and the federally qualified health centers so that it can become a really ongoing, mutually beneficial relationship. So there are ways to make this work, I think, within any community. It's a little bit different community by community, but there are definitely ways to do it.
Absolutely. And just one other caveat is, as Lynnzy said, the big picture, in the big picture, you know, patients are going to get better, and patients will be able to do a lot more self-management, consequently reducing the healthcare dollar being spent on that particular chronic condition in that particular patient. One of the things that starting in Colorado with the Medicaid voucher here, and I don't know if other states are doing it, but it would be lovely to be able to talk if they are, or talk with them if they are, is there will be some clinical outcomes done and measured to see specifically how healthcare dollars are saved through this program with Medicaid, folks on Medicaid. So hopefully we'll have some more answers on that in a year or so.
Thank you. We've had a couple of questions that have come up regarding whether or not you're willing to share some of those great forms that we saw the screenshots of, the patient referral form, the physician follow-up letter, those forms. Are those publicly available, and are you willing to share?
Yes, we are willing to share, and we'll be happy to do that. I would also be happy to share that process form. I only wish it was as easy as it was to put together the slides, but but yes, I'll be happy to do that. And if you want to, I can send you the form, or you can give us a call, or you can also look on our website and send me an email from them. It's coaw.org, and there's a contact button there, and we can send you those materials.
Thank you. And can you just do a quick repeat of the CDSME, the self-management education components that need to be documented in the electronic health record as required by NCQA? And is there a template or a screenshot of that, or perhaps maybe we can even share the slides from this PowerPoint presentation with us?
Yeah, happily. I think that slide is a really good one because it gives you kind of an overview. You know, CDSME, or the Chronic Disease Self-Management Program, is not the only program that will work for this. We just think it's the best because it's the gold standard. What is necessary for the NCQA is to have community resources, a list of community resources available, and to help connect patients to self-management education. There's also a piece about connecting patients and giving patients self-management tools. Now, a tool can be something like a food journal, a blood glucose journal, an action planning form, tips to release stress. All those kind of things can qualify as support materials that are handed the patient. Also, though, referrals to community-based organizations or to self-management opportunities are a part of it. So if, for example, you want to refer someone to a self-management class, that referral and then printing out that referral, those two pieces can be used to help document the work you're doing for Standard 4. The actual, them attending the class just gets you a much healthier patient. But the actual having the knowledge, the connection, and the referral to the class is what helps you with the NCQA piece. The other part it will help with, though, is having patients that come back and are able to be more engaged in the process that allows you to do those goal setting on an ongoing basis. But one of the things that folks that are going through their NCQA work will know is that over, I believe it's 50% of your patients, your chronic condition patients, need to have a goal, a self-management goal, within their care plan, either in their files or in their EMR. And that is something that is tricky to set with a patient, because if you have never been exposed to what goal setting is, action planning, what's the difference between saying I want to lose weight, which is a goal, to I'm going to walk 3 times a week and take my diabetes medications. So those are patient goals and action plans, and those kind of things need to be seen within all of the, or a good percentage of the patient files. And so that skill set is one that is hard to teach a patient within an office visit, but is very teachable and doable within a community-based class. So I would say Standard 4 is very important. Standard 3 clarifies what the difference is and how to document a care plan and a treatment plan and a self-management goal. So those are the 2 biggies.
Great. And we still have a couple of questions left, and I want to make sure we have time to answer as many as possible. So is the certificate from the class that shows successful completion? I know that a number of the workshops, the participants who attend 4 out of 6 get a really nice completer certificate. Is that a required document to be included in the EHR as part of the NCQA process?
No, it is not. Documenting the referral is the biggie. What we do as an added on is to document whether, how we're following up the referral, if they're attending, and then what their attendance is. But the actual certificate of completion is not required.
Thank you. And then a question from a community-based perspective. If it's a community-based organization, they have an infrastructure already for CDSMP, they have leaders, they have a coordinating process, and they're looking to engage a federally qualified health center. What do you think are 1 or 2 core messages that they should include when they're reaching out to the FQHCs to demonstrate to them the value and the impact of this program?
I would find out, first of all, if they already are patient-centered medical homes, and if they are or they are not, to know a little bit more about the language of what a patient-centered medical home is, and then to contact them and say, I understand you're a patient-centered medical home, and part of what that means is self-management for your patients and self-management goals for your records, and we can help you with that. And then be willing to understand that they're going to need to lean on you in terms of how to get their patients into the class, that you can help teach them those skills in a really short, quick, succinct way.
Thank you. And can you speak a little bit more about your experience in partnering with the FQHCs that you have up and running now? Is COA, is there a coordinator there at COA who's responsible for coordinating those workshops or coordinating workshops in the communities for the FQHC? And are any of the workshops being reimbursed through the FQHC?
They are not currently being reimbursed through the FQHC. We are looking to have them reimbursed starting in 2013 through the different Medicaid, Medicare programs coming through. We're also working on reimbursement for the diabetes self-management program in some of our locations in Colorado. That's a project that's in the works. And that's the diabetes curriculum is the only one right now that's directly reimbursable through Medicare. But there's a whole process that has to happen before that's possible. But we're learning the process. What is happening with the FQs is, and I don't remember the rest of your question. I just lost the first part of the question, Christy. I'm sorry.
Oh, no, that's fine. I think it was more about the role of the community-based organizations.
Yeah, and the coordinators. That's right. Okay. What happens, how we do it is that we have coordinators on staff here that, and we have one coordinator who works specifically, our pal Josh Pfeiffer, who comes from, he's worked with several different federally qualified health centers and safety net clinics, and so he can speak that language. He's an MA by training, and what he understands is what it's like within a clinic on the ground, working day by day. So he helps with setting up those classes, the referral process, and calling back the referrals, as does the rest of our staff. But it's really his baby in terms of working with the classes. Then we all get involved with it, and sometimes it means a community-based class that a AAA is offering, but we say, how would you feel about doing the class instead of at your office or at the rec center? How would you feel about hosting it at the clinic site? And so, so that's kind of how we work it. So it's part of our ongoing day-to-day work, but I would say it's becoming a good portion of what we do.
Thank you. And is there a quick and easy way that an organization can learn whether or not a federally qualified health center is either a certified patient-centered medical home or is going through the process of becoming certified?
Okay, the quickest way I can think of is I'd call them. I would call them and I would say, you know, are you a patient-centered medical home? Or look at their website. They have all worked so hard to do this that it will say on their website, we are proud to be a level 3 patient-centered medical home. But the truth of the matter is, the transformation is whether they're applying under the NCQA guidelines or the other guidelines, the whole care coordination piece, the Affordable Care Act, all of this transformation is taking place nationally. So the easiest wins would be to work with the people that are looking at NCQA or some other patient-centered medical home designation. But every FQ is involved in this transformation. And nationally, the FQs are really being looked at as the model of care and of really being able to serve broad communities. So you are probably safe contacting any FQ and asking about their status.
Thank you. And one final question. For those federally qualified health centers that have already gotten up and running, what are you noticing so far as participant recruitment and retention? We know that sometimes, you know, filling workshops can be the most challenging thing, and then, you know, simultaneously retention can be a challenge as well. So what has your experience been within that setting, especially with populations that perhaps do have challenges regarding access to transportation, persistent chronic conditions, etc.?
I wish I could give you a really good, quick answer on that one. What we're noticing is that it really varies class by class. It really varies flu season, not flu season. Really varies what the primary diagnosis is of the person in the class. I think anybody who's done these classes knows chronic pain patients tend to miss more classes, for example, than patients with arthritis or diabetes. So what we see is it really varies a lot, and so far we have not seen any great difference in terms of retention and completers in that population or within an FQ setting than we do in other settings. And I would say it's a couple of points lower, but it isn't enough that it's a huge difference in terms of planning. What I would say, though, is what we do see are the gratitude and the light bulb moments of the folks that are the FQ population, those that are vulnerable or have not had as much access to services. When they get it within a class like this, when the light bulb goes on, it really changes not only how they work with their own system of support, but it changes their families' lives. They talk to their friends about it. It impacts the whole practice as well. So you can't really measure that in the same way, but it's really meaningful work, and the classes are really meaningful within those locations to the people that are participants.
Wonderful. Chris and Lynnzy, thank you so very much for this presentation. We got great feedback via the chat, great questions, and I know Chris and Lynnzy personally, they're very, very willing to answer additional questions. So for those of you, who maybe later on today or tomorrow morning another question pops into your head, they're great about answering your questions and helping you out. So Chris and Lynnzy, thank you so very much. And I would like to turn it back over to Dr. Webb to close us out.
All right. Thank you so much. First of all, Christy, I have to thank you very much for moderating the session. It has been truly phenomenal. And again, I would like to thank the speakers from COA, Christine Katzenmeyer and Lynnzy McIntosh. I think you shared some very, very insightful information, and I can tell you from firsthand experience how applicable this is, especially to the FQHCs that want to continue to provide a patient-centric model of care for their patients. And I think, for most of the community health centers who use community health workers, I think it's a phenomenal opportunity to get them trained as well to be possible facilitators and leaders in a chronic disease self-management program. So again, thank you so much for the information shared. For those of you who would like to if you have any further questions, feel free to reach out to either Lynnzy and Christine at COA, at coa.org. That's their website, and you'll be able to contact them directly through there. Feel free to reach out to us at the National Center, and we will be happy to get the information so that your questions can be answered. So again, everyone, thank you for joining us for today's webinar. Thank you to all of our speakers, our facilitator, and we hope that you will all implement chronic disease self-management programs at your FQHCs. Thank you, everyone, for joining us today.